Okay.
If you could just give us that, and then we'll go live very, very shortly.
And can I ask, just while we're waiting on that, because we're fully virtual today at the request of clerks, I'm doing this on an iPad. Does anybody know, is there a button I can click on the screen to see everybody, or am I only able to scroll through the pages? Oh boy. Okay, this will be fun to chair.
Yeah. If Joe,
Good morning, members.
You could potentially
I just wanted to let you know we're now live on YouTube.
Oh, okay.
The live stream has started.
Well, thank you. Good morning. My name is Joe, and I have the privilege of working alongside and chairing the Board of Health. I say alongside because we have all our directors here today. The board secretary has confirmed that we have quorum, so I'll call meeting 24 of the Board of Health to order. Welcome, everyone. Today's meeting is being held by video conference. City staff are connected to the meeting by video conference. As City Hall remains closed, the public will continue to participate electronically and can watch the meeting streamed live on YouTube at youtube.com/Toronto City Council Live. I'd ask members of the board and city staff for their patience as we deal with any delays and technical issues. And I would just include in that we are fully virtual and remote today, including myself, which means that I can't see every single board member on a single page. So I'll be scrolling through looking for hands when I'm requesting speakers and doing votes. So I'll ask for your indulgence as we work through that. We do have 2 registered public speakers today, and city staff have connected them to the meeting by audio. And with that, I will note that although we are in different locations and meeting remotely today, as we have been doing for nearly a year, the Board of Health would like to acknowledge that the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. As we begin, could I ask if there are any declarations of interest under the Municipal Conflict of Interest Act? Given that I can only see one screen in front of me, I'd ask if you have an interest, if you could unmute your mic and just state your name and state it. So are there any declarations of interest under the Municipal Conflict of Interest Act? Okay, seeing none. Next, we need a motion to confirm the minutes from our last board meeting on November the 16th, 2020. Moved by Councillor Lai, thank you. By way of a show of hands, all those in favor? If any is opposed, okay, seeing none. Okay, we're going to do an agenda run through here. The first item is HL 24.1 TO supports the COVID-19 Equity Action Plan. We have a presentation from staff on that. The second item, and we have a speaker, is item HL 24.2 response to COVID-19 update. Again, we have a presentation from our Toronto Public Health team on that one and a speaker, so it will be held down. Item 8, number 3 is item HL 24.3, appointment of Associate Medical Officer of Health. There is a staff report and a supplementary report as well. Would anybody like to hold this item?
I'll move the staff recommendations.
Okay, staff recommendations moved by Councillor Layton. By way of a show of hands, all those in favor? Opposed, if any? That carries. Thank you. And can I just check with Julie from Clerks? The staff recommendations have moved. Nothing else needs to be moved on that item with a supplementary, correct?
So, Mr. Chair, we do need to move a motion to move the recommendations in the supplementary report.
Okay.
I'm wondering if my colleague Nydia can actually display those on the screen.
Okay, so the recommendations were there, and then the supplementary recommendation contained in the confidential report, which is for City Council to authorize the public release of the confidential attachment once City Council appoints the physician recommended for the appointment as AMOH. Councillor Layton, could you move that as well? I can't see you. Do you want to just unmute to indicate? Sorry.
Yes. Yes,
Thank you kindly. Okay, all those in favor of the staff recommendation and the supplementary? Any opposed? That carries. Thank you very much. The next item is item HL 24.4, Performance Appraisal, Medical Officer of Health. There is a letter from the Board of Health Performance Appraisal. This is the subcommittee with recommendations, and with my deep gratitude to Director Mulligan and Councillor Wong Tam, who alongside me were members of that subcommittee. Councillor Wong Tam or Director Mulligan, would you like to move the recommendations there?
With pleasures. It's Councillor Wong Tam.
Okay. So recommendations from the subcommittee have been moved by Councillor Wong Tam. All those in favor? Okay. Opposed, if any, that carries. And then item HL 24.5. This is the 2021 schedule of Board of Health meetings. These are the pre-scheduled meetings, though I would note that I think board members, given the workload, should anticipate that there may be additional ones. Would anybody like to move the recommendations in front of us here for the 2021 meeting dates? Moved by Trustee Donaldson. Okay, all those in favor? Opposed, if any, that carries. And then we have one item of new business that I would like to introduce, but we will hold down so that members have a chance to read it. This is a letter submitted by me working in partnership with our school boards on the student nutrition program and some immediate measures to support the allocation of resources for those who are experiencing virtual learning due to closures or regular virtual learning during COVID. And so that's going to be a new business item introduced, but we will hold it down so that members have a chance to review it and we can deal with it later. So this is a motion to introduce that new business item. And with deep thanks to Trustee LaPretti, who has helped on that from the TCDSB as well. All those in favor of introducing that item as new business? Opposed, if any? That carries. Okay, so that means we have 3 items in front of us today. Our first item is HL 24.1. This is TO Support, COVID-19 Equity Action Plan. There's a staff presentation, and so we're going to have the staff presentation first, and we have Juliana Carboni, who is the Deputy City Manager, as well as Denise Andrea Campbell, who is the Executive Director of Social Development, Finance and Administration from the city. They will be providing a presentation here. We will then proceed to our registered speaker on the item before we go back into committee for questions. And so with that, I'm going to turn it over to Juliana Carboni and Denise. That is, unless Dr. DeVille, you wanted to say anything off the top on this.
Sorry, Mr. Chair, just wanted to make, there we go. Now I'm on video. Thank you. I will defer now to Juliana and to Denise, our colleagues from Community and Social Services and SDF&A. But thank you.
And can I say that it is always wise to defer to our colleagues at SDFA. That always steers us well.
It always does. I would agree wholeheartedly. Thank you, Mr. Chair.
All right, so let's begin with the staff presentation. Juliana and Denise, it is in your hands and with our gratitude for your work, but I'll let you provide the presentation. Over to you.
Well, good morning, Mr. Chair, directors of the board, and thank you for this opportunity to present and summarize the city's consolidated COVID-19 Equity Action Plan. Joining me today, in addition to Denise, are many other leaders and many staff that are behind this plan. And as you'll see, this is very much a corporate effort. TO Support, as we've named it, was first launched in March, shortly after the emergency was declared. And it was really to respond to the urgent needs of communities, those hardest hit by COVID and the effects of the lockdown. And it is very much a multidimensional plan, and it's built on a strong partnership with the community not-for-profit sector. And it is a plan that is constantly evolving and adapting based on and in response to new data and information, emerging pandemic conditions, changing public health guidance, new partnership opportunities, and new and emerging needs. Next slide, please. There are 3 key messages that I want to highlight today. First is the critical importance of the community sector in working with the city as committed partners in monitoring and understanding what's happening on the ground and how this pandemic is affecting communities. helping us identify urgent and emerging needs and issues, and designing and delivering new services and supports, or pivoting our existing services at really an unprecedented scale and with unprecedented speed, all to meet the needs of vulnerable families, residents, and Torontonians. And there is no doubt in my mind that without the work and strong partnership with our community agencies, many Torontonians would be much worse off. And in order to rapidly and effectively respond to the changing needs we're seeing in communities, the city's COVID Equity Action Plan includes some brand new lines of operation and brand new partnerships, all designed and implemented within mere days or weeks of the emergency being declared. And you know, looking back, I really do think that these innovations demonstrate the powerful capacity of the city to be creative, to collaborate, and to be nimble. And the final point to keep in mind is that the city's ability to effectively address the inequities that have been magnified and made worse by COVID is really dependent on a strong and ongoing commitment from the other orders of government, both in terms of funding, but as well as legislative and policy support. Next slide, please. So as you are all aware, COVID is not affecting all Torontonians equally. This illness is disproportionately impacting Black and racialized populations as well as Indigenous populations. So what you see on this slide is Public Health's recent map of infection rates. I'm sure you're all familiar with it. So the darker the blue, the higher the rates of infection. The highest rates are currently in the northwest and the northeast parts of the city, so in Etobicoke and Scarborough. And these are neighborhoods that for many years have experienced health disparities, all due to the social determinants of health. These areas have larger proportions of residents who are living on a low income, who are precariously employed or work in essential services, and whose housing situation really makes it difficult for them to isolate if they're ill. Next slide, please. So what COVID has done is magnified, as I said, the long-standing systemic social and health inequities related to poverty, racism, and other forms of discrimination. And in order to support those hardest hit by COVID, the city had to rapidly connect with its strong network of community agencies to develop and roll out a robust plan that frames and guides the city's COVID equity response. Next slide, please. So right from the onset of the pandemic, our teams were very much focused on responding to the urgent needs of vulnerable residents and communities. In March, we started having daily calls with over 70 community agencies, public health, and a number of city divisions, all in order to share information and insights, formulate responses. And then we quickly worked with United Way to organize over 400 community agencies into what we call clusters. And that was all in order that we could work together to identify needs, to strategize and coordinate local responses, to distribute donations. So 10 of the cluster tables are dedicated to geographic areas in the city, but we also have a table that's focused with working with citywide agencies, another one with Black mandated agencies, and of course we have ongoing collaborations and discussions with Indigenous organizations. So we refer to these tables as our community coordination tables. And at the start, working with these tables, there was 8 areas of high need that were identified. They're captured here on the slide. And then, once we understood what was needed, we quickly mobilized a whole range and host of services to be able to respond to those high need areas. Next slide, please. So since that time, the plan has evolved, again, based on new data, changing conditions, new insights, et cetera. So this is our current framework. We now have 10 areas of high need, and we have 25 actions associated with those areas. And most of them are being implemented with our community partners. The actions relate to community and outreach, access to community health services, support for community agencies, shelter and housing, income support, food security, seniors, digital access, mental health and family safety, and children's services. So the full plan with all 25 actions detailed is in attachment 1 of the report that's before you today. Next slide, please. So this is just a sample. Oh, sorry, I think we've, okay, I had another slide, but I guess maybe it got missing. There was a slide, so let me just before I talk to this slide, I had meant to include a slide that sort of demonstrated what the layout of the attachment looks like. So for each of the 25 actions, you're going to have a page or two that at the very top summarizes the priority need area. We then identify the specific actions. At the bottom of the page, you'll see the city divisions or agencies that are involved in leading the implementation of the action. The main section just highlights what's happening, what we're doing, and what's underway. There's also a section that summarizes any work that we're doing with our intergovernmental partners, so with the province and the feds. And on the right side of the page, there'll be a box that sort of identifies what the status of the action is, whether it's in progress or achieved. And there's also a box that captures advice that we've heard from communities and how the city is responding to that advice. So in terms of this slide, I'm not going to go through all 25 actions and everything and all the key accomplishments, but I do want to highlight some key innovations. So access to food has and it continues to be a pressing area of need. It's an area that traditionally the city hasn't been involved in the service delivery of that particular service. However, within days of the lockdown, it became very apparent that many emergency food supporters were closing. And the city quickly partnered with food banks and the Red Cross to ensure that vulnerable communities continue to have access to food. We repurposed city facilities to support the food banks, and we invested in food delivery for persons that were isolated or couldn't leave their homes. And we also reinvested the student nutrition grants into grocery carts for families whose children could no longer receive meals at the school. Mental health was also an area that before the city had not traditionally been involved in, but realizing the clear need for mental health supports during this pandemic, we partnered with 211 and a wide range of mental health providers to ensure that residents in need had access to telephone-based counseling and supports. And thanks to the contributions of many telecom companies, we had free phones and tablets distributed to shelters, to social agencies, and vulnerable residents. We have free Wi-Fi provided to all of our 10 long-term care homes, to some of our shelter sites, and in 6 apartment buildings that are located in low-income neighborhoods. There's an additional 19 apartment buildings that are going to receive free Wi-Fi. Those hopefully will be completed in 2021. We just have to wait for pandemic conditions to allow for the safe resumption of the installation of that service. And the city also has developed and put online hundreds of free programs for residents of all ages, and that's to offset the loss of our in-person activities. Next slide, please. So, as I said from the onset, our community not-for-profit sector is a critical partner. And as such, we worked very closely with the sector to understand what supports and resources they needed, what supports community agencies needed in order to continue to operate safely and effectively throughout this pandemic. So the city supported the sector by flowing emergency funding to agencies in need. We leveraged and distributed donations. And we continue to remain close to the sector through those community coordination tables that I referenced earlier. The city also continues to support people who are experiencing homelessness. Within a few short weeks of the emergency being declared, the city successfully opened over 40 new locations in order to create physical distancing across the shelter system. Marianne and her team in FSHA undertook heroic work to make sure that that happened, and 25 of those sites are currently operating today. In addition, we've connected over 2,500 shelter clients to permanent housing. And we've leveraged a variety of housing benefits, rent geared to income, et cetera, in order to be able to do that. And we've helped over 1,000 people that were living outdoors move into safer indoor spaces. And our housing secretariat is very much focused on building and opening affordable and supportive housing, leveraging city investments, our open door program that council has approved, and the federal rapid housing program. The first of these units will open by the end of the year, and by the end of 2021, we are targeting over 600 supportive affordable units. Next slide, please. I think you're all aware that the city opened Canada's first voluntary isolation site. As well, we are operating a recovery and isolation site for our homeless population. We continue to provide and offer city facilities to help meet emerging needs, such as pop-up flu clinics and testing sites. And we've also repurposed some of our TTC buses for mobile testing and also to help move residents to and from testing sites. Next slide, please. So as I mentioned, the city's Equity Action Plan is continually evolving. And most recently, Council approved very specific equity measures for areas of the city with high infection rates, so starting in the northwest and the northeast. The targeted plan allows for refined actions to target to those communities that are really hardest hit by these high infection rates, such as Black Torontonians, who continue to face the highest rates of infection, given their concentration in frontline service delivery and housing insecurity. The targeted measures include working with the province to increase testing capacity. So I mentioned the buses and offering city facilities, and we're working very closely with the province to see how we can both increase the number of testing sites in high needs areas and also the hours of operation. We're partnering with local agencies on delivering targeted outreach, case management, and other supports directly to residents in a way that is culturally and community appropriate. And the reason the community sector is so important here is that many residents trust and have a relationship with those local agencies. So we'll be much more effective in working through those agencies in order to achieve this. We're also advocating quite strongly with the provincial government for income support so that residents don't resist testing or isolation for fear of losing their job or losing their income. We're also advocating for eviction prevention measures to ensure that lower income households can continue to maintain their housing throughout this pandemic and afterwards as we move on to recovery. Next slide, please. So that concludes my presentation, and the team is all here to help respond to any questions, Mr. Chair, that you or the directors might have of us.
Well, thank you, Juliana. And for members of the board, we have the privilege of hearing from and speaking with our Toronto Public Health staff on a monthly basis. But I think you just got a small glimpse into the exceptional leadership and the compassionate work that the entire city, led by Julia Carboni and her divisions, do. So thank you for that, Juliana. We have a registered speaker on this item, so we're going to hear from the registered speaker and then go in camera for questions. And so I'll ask the clerks, do we have Jennifer Scrow connected on the line?
Good morning, Councillor Cressy. We do have Jennifer Srow on the line.
Jennifer, are you there?
Hello, can you hear me?
We can hear you loud and clear. Jennifer, you'll have 5 minutes, and I'll start your time and at about 4 minutes and 30 seconds, give you a heads up that you're approaching the 5-minute time. So you can begin when you're ready.
Great, thank you. And good morning to all, and thank you for the opportunity to speak to you today. My name is Jennifer Scrow, and I live in one of the hardest COVID-hit areas of Toronto. My 2 children attend a hotspot school. Our elementary school has had 8 positive COVID cases in the past 28 days. 5 of these cases have been in the last week alone. Yesterday afternoon, an outbreak was declared in our school, and a few hours later, our school was dismissed for the week. All 8 of our positive cases have been asymptomatic. The very first positive case was in my son's kindergarten class. Although his entire class had to isolate, we were told that our 7-year-old daughter could continue to go to school as long as she remained symptom-free. Again, the child who tested positive in his class was asymptomatic. How could I possibly send my daughter to school knowing there was a chance she could be asymptomatic and pass the virus on to her classmates and her teacher? When I spoke to public health, I was told that the hope is that the child who was in the closest contact to the positive case isolates from the rest of the family. My son is 4. That's impossible. While I'm cognizant of the privacy issues surrounding testing and results, I'm urging the Board of Health to re-examine the use of mandatory asymptomatic testing in our schools. I understand that making testing mandatory will probably cause outrage among many people, but I can also tell you that by not making it mandatory, you're not going to yield the results you need to continue making schools safe for our children and their teachers. People are not going to test voluntarily if they don't have to. It's just not going to happen, especially in the neighborhoods that are hardest hit. Where I live, there, you could take an example of one of the schools that did it just south of us in the Maple Leaf area. My parents live in that community. They have one of the highest positivity rates. Out of 700 high school students that had access to the testing, 63 showed up. 63 out of 700. People are no longer buying into this threat, and now COVID is in our school and it's working its way out into the community. I urge you again, please do what is in the absolute best interest of your children and make asymptomatic testing mandatory in our schools. By not doing this, we are not going to get ahead of this virus. We cannot fight what we can't see. It's just not possible. I can't keep my children safe from this virus if I can't see that they have a runny nose or if they're not feeling well. I can look at my screening passport. I can go over all the questions and ask my kids and take their temperatures. But if they're feeling fine, I'm going to send them to school. And if they're asymptomatic, they're passing it on to their friends, to their teachers. They're bringing it home from other kids who are asymptomatic. Thank you for the opportunity to speak. And if you have any questions, I'm happy to answer them for you.
Thank you very much, Jennifer. Let me caucus members of the board. Are there any questions for Jennifer? And I'd ask if you have questions, if you could indicate so by just unmuting your mic and stating your name, as I can't see everybody on my screen in this format. Okay, seeing no questions. Thank you very much, Jennifer. To our clerk's office, just confirming that we do not have any other speakers on this item registered.
That's correct, Mr. Chair. We only have the one.
Okay, thank you very much. So that means members of the board, we're taking this into committee. And so we have an opportunity here for questions of staff. We heard from Juliana Carboni, but I can tell you that many members of her team are here, as are, of course, representatives from Toronto Public Health. So could I ask, are there any speakers or members of the board who have questions on this item? I see Councillor McKelvey. I'm going to draw a list here. Others with questions? Councillor Wong-Tam. Any other members of the board with questions on this item? I'm just checking on my other screen. Councillor Lai, I see. Thank you. Okay, so and Trustee LaPredi, thank you. Okay, so we will begin. So we'll have 5 minutes. I'm doing this on a phone simultaneously because we're not in committee room 1 today. So I'll do my very best. Councillor McKelvey, soon to be chair of Infrastructure and Environment. Congratulations. I should note for members of the board who are not aware, not an insignificant deal at all. Councillor McKelvey, when you're ready.
Thank you, Mr. Chair. And while it is a good opportunity to be Chair of Infrastructure and Environment, it does mean that I am leaving this committee to take on new responsibility. And I very much enjoyed my time with all of you and working on these very important matters. My question is about the high rates in the Northeast specifically, and I think the same question pertains to the Northwest as well. But I know that you've just started to roll out the TTC bus testing, and I just wanted to know how well that has been working and how you're seeing this potentially being expanded. And I know that you're doing two things. So one is using them for actual testing, but also using them for transport to testing centers. So could you just maybe speak to how well it has worked and how many you've done so far?
So I'm going to ask, I don't think we have anyone from the TTC, but if Denise can maybe augment, because I know she's been working very closely with our TTC partners.
Sure. So good morning, committee, and good morning, Councilor McKelvey. So the commitment to increase mobile testing started in the Northwest with, as you noted, with both using TTC to support mobile testing sites, as well as increasing sites in community spaces and other city facilities. So we've been working with public health and our partners in the Ontario Health Region to try to use as many options as possible to bring testing as close to people where they live, as well as to deal with any issues of getting them there or having expanded hours. The TTC has been great in committing extra resources of buses that they're not using for regular routes to support this effort both in the Northwest and in the Northeast.
I don't think there's been any rollout to the Northeast. Do you know when you're expecting to see that initiative moving to the Northeast as well?
So my understanding from my colleagues in the EOC, the Emergency Operations Center, is that work is happening currently to plan and that on the city's website, I'll have to look exactly where, but there is information about testing locations as we bring them on board. So my understanding is that this week there should be some additional sites in the Northeast. And we can certainly follow up with the Northeast councillors to provide that detail.
Yeah, so that would be myself and Councillor Lai, who's probably going to ask similar questions to that effect. So thank you very much. I was happy to see the initiative in the Northwest, but I am interested in seeing it expanded. And then my last question kind of builds on that. How do you advertise that they're happening and in what languages? So for example, in the Northeast, I think it's much needed, but if those materials should be distributed to door and door to door, but they should also be in multiple languages. So is that a potential for us to do that as well?
So I think certainly can defer a little bit here to the medical officer's health team. But the one thing I will say is I know that through this initiative, there are multiple efforts being made to get the information out to as many residents where they are as possible. So some of that is being done through public health. Some of that is being done through community agencies that we've contracted as partners in this work. And I think I've seen updates from the EOC that certainly says translation into multiple languages, particularly in those areas, are part of the effort. Eileen?
Yes, so thank you for that, Denise. You're quite right. The advertising is done through a series of partners, and part of it depends on who is the testing partner that's engaged. They have their many networks in the community, and certainly language and a variety of languages, appropriate languages for the population are part of that process. I think the other, just to your earlier question, Councillor, there have been a number of pop-up sites in the Northeast done in concert with a number of different community agencies. But of course, as the TTC program starts to roll out, you should expect to see some locations in the Northeast part of the city as well.
Great, thank you very much.
Thank you very much, Councillor. Next, I have Councillor Wong-Tam.
Thank you, Chair, and thank you to staff for your excellent presentation. I recognize that it actually simply represents a quick summary of the thousands of hours that have gone into responding to the COVID emergency. With that, I wanted to just lean into a few points. And in particular, I'm actually going to focus my remarks and questions on the attachment number 1, which is the intergovernmental requests and responses around COVID-19 recovery. Because much of what we have seen in terms of the City of Toronto's response to COVID and what is coming out of the action plan, especially putting an equity lens on it, is that there are still some existing gaps. And in particular, I want to just ask the question around mental health support and services, because whether or not it's true or whether or not this is a number that's validated, but we're seeing the rise of mental health challenges for Canadians and Torontonians, especially through the prolonged lockdown, the further social isolation away from family, for those who are living homeless and perhaps who are under this incredible stress of being an essential and health worker. And yet mental health services is not something that cities are generally mandated to deliver. So here we are. We're facing what I believe is a mental health crisis that is now mounting itself and growing. We're not, and based on your report in the attachment number 1, what is the service gap that we need in the city of Toronto to meet this mental health demand for service? And what is it that the province and the federal government has given us? And what are we missing? What have they not given us? What's the gap?
So let me start, and maybe some of my staff could augment. We know that in order to successfully house and keep people housed, many of them need support, mental health and addiction supports, and it's ongoing. We've had some luck, or we have been provided with some dollars from the province for supportive housing. Our challenge is it's one-time dollars. Right now, we've got dollars to the end of March for some of the units, but we know very well that these supports have to continue beyond March. We need ongoing dollars to help support individuals to meet their mental health. They need mental health supports, addiction and harm reduction supports, and we estimate that it takes, in addition to the housing costs, it takes around $24,000, I think, a year per unit to provide all of those wraparound services, of which mental health and addiction support is a very important component. And so, but having said that, Eileen and I have constant discussions with the province so that they can understand the challenges that we're seeing on the ground and the types of needs that these individuals have. It's in everybody's best interest to have people housed, and we're determined to have a stronger partnership with our provincial and federal counterparts to make sure that the units we're building, 600 in next year, will have the right supports attached to them so that individuals can continue to be successfully housed.
Yeah, so if I may, Councillor, I think Juliana has described exactly what needs to happen quite well. I would suggest from a city perspective that there are a couple of things. For the city, where we can engage best is probably in creating conditions that allow for better mental health promotion. But when we're actually talking about very specific services, and in particular when we're talking about mental health care and treatment, this is something that really we need our provincial counterparts as the leads on healthcare and that kind of service provision to take the lead on. We're certainly having those conversations with them, but we see there's a continuum of service that needs to be offered. Certainly there's much we can do as a city to create circumstances that are more likely to lead to better mental health. Opportunities to engage in outdoor physical activity may seem like a small thing, but in fact, it's a pretty significant contributor to mental health for many of us. Creating community or supporting the ability for community networks to develop and flourish is another example of the kinds of things that we can do from a city perspective that would have significant public health benefit. But clearly mental health care is something that we rely on our provincial partners to take the lead on, and we are actively in conversation with them at all moments on that.
Thank you both for that response. I wonder if has the advocacy also been taken up with the provincial agencies and hospitals that receive provincial dollars? Because ultimately they're the ones who are delivering the service. It's not like the City of Toronto has a division of mental health services, right? So how is that partnership being reinforced? Because what I'm hearing on the ground, and this is perhaps the sticking point, is that all these provincial agencies and hospitals are aware of the service deficiencies. They say they don't have the bandwidth or the resources to deliver, and yet it seems to me that the city is making the requests as opposed to perhaps the hospitals or those health agencies that are funded entirely by the provincial government mental health supports. So how does requests from us get strengthened and amplified with their support and perhaps in partnership with a few other critical players that aren't at the table with it on the daily calls with you?
And just before you answer, staff, I'll note that we're just over 6 minutes, and so that we'll then see if there's a second round of questioning after this.
That was 6 minutes. Okay. Thanks.
So I can tell you, Councillor Wong-Tam, that we are having discussions with the University Health Network as well as St. Mike's. They both understand and agree with our position in terms of the need for mental health and addiction support. So we're trying to build that stronger partnership so that our advocacy is heard at the province, so that it's not just the city advocating. But Eileen might want to augment as well.
So if I may very briefly, there are clearly some issues where we're able to engage better than on others. I'll give you an example. So we have a task force that's been created, and it's a partnership between the Toronto Academic Health Sciences Network, Toronto Public Health, and a number of community partners established to look specifically at the opioid poisoning crisis. And there is, shared work that is happening amongst these partners. And I recognize that's only one particular issue, but a very, very important one. And I think it sets a model for the kinds of things that we can do. It is very action oriented. It is seeking funding in order to deliver as best it can on the promise that exists. But I think that's one example of the kind of thing that can happen. And I imagine that there isn't any reason why similar collaborative partnerships couldn't occur across the spectrum of mental health needs.
Thank you. And Councillor, we'll come back for a second round if you'd like as well. Next up, I have Councillor Lai, followed by Trustee LaPretti.
Thank you, Mr. Chair. Like Councillor McKelvey, this will be my last meeting too off the board. So I just wanted to thank everyone for teaching me. There's a lot that I've learned in this board, and I mean, even during COVID, because board of health is very important. And I just wanted to actually, Councillor McKelvey has asked most of my questions, and just wanted to elaborate on the question of staff of the communication in multiple languages. I've seen some infographics that are coming out. Can staff tell me that how many languages? Some of those infographics, I don't think it's enough, but can staff tell me that how are they communicating to the people that don't speak English? Because to me they are the vulnerable, and I've got the email from my constituents that sometimes they don't understand what's going on, and it's very important that we protect them as well. So can staff tell me about the infographics? Are they in multiple languages? I assume they are, because they're in Chinese.
So through you, Mr. Chair, my understanding is we're translating our communication materials into 30 languages. Is it? I don't have the list of the 30 languages, but my understanding is 30 different languages that we're producing our communications materials in. Okay,
that is good enough. I just wanted, we can actually do more and better, because communication is key for people to prevent from COVID. The other question I would have is about the report. Thank you very much. It's a very nice report, and you touch on a lot about the equity measures. I've seen in your presentation that there, the racialized group, the care for the seniors, for homeless, and all that, mental health. Those are some of these equity measures. I'm just wondering, again, tell me, in this presentation or in this report, would it cover people that's first language is not English? I mean, they have a barrier, obviously, and I think it'd be very, very important that they're being communicated with the key messages, or they are being part of this this whole group of being equity.
So if I may, absolutely, Councillor Lai. So as we're taking from the beginning of this response, partnership with a variety of community agencies has been critical, both because agencies are, as I think as Juliana said earlier, trusted and knowledgeable about their local community. And they've been able, through the geographic clusters that we created early on in the pandemic, to be feeding back to us the multiple needs that the residents that they serve require. Part of this has been about ensuring that people who English is not their first language can understand services that are available to them. That's why there is this commitment and action up until now to keep translating information to the languages that are most dominant in particular communities and neighborhoods. And where possible, to use high graphic infographics as well as a means of communication.
Yeah. Okay, thank you. My last question would be, with the calls to the Toronto Public Health now with the helpline, are there would they be in different languages as well?
So through the chair, we do have we have some staff who certainly speak a variety of different languages, but as well we have access to translation services in order to support calls on an as-needed basis for whatever language is most easy for the caller to be understood and to understand the information.
Okay, thank you, Mr. Chair. Those are my questions.
Thank you very much, Councillor Lai. Next, I have Trustee LaPredi.
Hi, I have two questions regarding the delegation. My question is, are we considering making testing mandatory in schools to keep them safe? That's the first one. And the second one is, when can parents expect to see asymptomatic testing rollouts in schools, and what will it look like?
So through the chair, Trustee LaPredi, good question. Their testing, as you know, falls under the provincial purview, and it is a healthcare clinical kind of service. We are absolutely supportive, and we are participating in current testing pilots, asymptomatic testing initiatives that are happening, again, under provincial purview. It's a little more complicated than it might appear on the surface. It is, the tests are imperfect. They are good, but they are not perfect by any stretch of the imagination. That is the case for every test that is provided for within the context of medical practice. So and the issue, of course, is that there are challenges, as I understand, and our provincial counterparts are probably better to speak to this than we are, around the capacity within the system. So the question is how best to direct the resources in those places where they're likely to deliver the most value. So we have a current asymptomatic testing initiative underway. The province is the lead. We are one jurisdiction that is participating in this. My suggestion would be to let that continue to be implemented and to undertake the evaluation and to look at the evaluation of that endeavor so that we can make informed decisions around what would be the next best steps in terms of either scaling up, adjusting, or whatever makes the most sense given what they find from that evaluation.
Thank you.
Thank you, Trustee LaPredi. Let me just do a call. Other members of the board with questions. Okay, I see Director Mulligan. Are there any others, just as I create a list and then see if we need a second round? Caucusing around. Okay, so we'll go to Director Mulligan and then myself. Director Mulligan, when you're ready.
Thank you, Chair. I have two questions. The first is about the maps. So we're seeing that COVID-19 inequities continue to persist, even though there is this heroic effort happening at the city level with many components, new initiatives, short up initiatives, and so on. Excuse me. Could you speak a little bit, Dr. Davila, about evaluation of how we've done so far, and whether this work we think has mitigated COVID or it's the attendant impacts of isolation and lockdown?
So through the chair, an excellent question, and I don't know that there's a simple answer to that question quite yet. We know that you're quite right. Inequities persist, despite some very, very, heroic, I would characterize them as efforts on the part of many of my colleagues all around the city, and I can assure you within Toronto Public Health itself. I think some of the challenges are that what underpins and underlies the inequities that we're seeing in respect of COVID, is premised on circumstances that have been there for a very, very long time and will require significant work to address. That doesn't mean we should stop or that we should throw in the towel. I think it just tells us that we have significant efforts to undertake now during COVID, and I would argue beyond that. If we are serious around the intention to improve health status in our community and to reduce inequities, this is fundamental to public health. We have big investments to make and some significant evaluation to undertake and plans to develop premised on that evaluation. I think we have a partial picture at this point. You're going to see a little bit of that, a little window into that premised on one of the next report that's coming on the agenda, but it is by no means complete, but it is a starting off point, and it is something that we are actively looking at and that we will need to continue to look at, both as Toronto Public Health, I would say, as the city writ large, and certainly from the provincial perspective as well.
Thank you. And I have one more question, and it's about vaccination. So Denise and Julia and Eileen, all of you mentioned the trusted relationships that community agencies have with very marginalized communities. And I'm wondering in what way, if at all, the preparation for vaccination is related to the work that has been done around testing and wraparound supports and other initiatives with these communities. If you could speak at all to how we're preparing for that, that would be fantastic. Thanks.
So perhaps I could quickly start and then throw it over to Eileen. So as you saw in the slide deck from Juliana, the fourth area of work is to leverage what we are doing now, to your point, Kate, to prepare for immunization. We anticipate that some of the communities with the higher concentrations may also have immunization hesitancy. So we are getting advice from the community partners that we're working with. As communication materials are being developed, we're asking them to also think about how this pivots or evolves into immunization support kind of messaging. We're also looking to see potentially if faith leaders in some communities can play a role, potentially, maybe being among some of the first to get immunization in order to be able to share this message with those that are part of those communities. So we're trying multiple things, now seeing these things as quite connected, to your point. Eileen?
Thanks, Denise. I think you've captured it very nicely. And I think that over and above, the community agencies that have established relationship and trusting relationships with their communities and clients, we need to bring in, healthcare partners who have trusted relationships with clients, faith leaders, social service and community service agencies. I do think that this is an all hands on deck. The part that I think we need to be upfront about in terms of concern is that we know that these agencies are also, they are also stretched and feeling the pressure. So we're trying to, be respectful of that. And at the same time, it's a very delicate balance to ensure that they're engaged and at the same time recognize how best do we ensure that they still have the capacity to do what they need to do and to be mindful of themselves, given the many, many pressures that COVID-19 and the response has placed on them over the last several months.
Thank you.
Thank you, Director Mulligan. Can we do a call if there's a request for a second round? If not, I'm going to put myself on. So Councillor Wong-Tam. So I'm going to put myself on, and then we'll do a second round for any who wish. And I see Councillor Wong-Tam there. So let me kick it off just for myself, and I'll start my timer. And I'll start to Denise and Eileen, jump in where you'd like. The report speaks to family isolation. So we have an isolation center currently in operation that TPH operates and the feds fund. it speaks to the need to identify increased supports for families who need to isolate. Can I just get an update on what the status of that work is and what we might expect to hear coming forward?
Certainly, Councillor Cressy. So in exploring potential barriers for people to access both testing and isolation if required, it's come to our attention that families that are underhoused or that have dependent children or dependent elders may struggle in order to go, for an individual to go to the current voluntary testing site. So we're working through with public health, with a variety of other partners. We're looking at other jurisdictions around, can we bring different kinds of supports if the individual needs to go to the voluntary isolation center but needs childcare or elder care support in home, as well as is there a safe model that we can develop where a family might be able to isolate together outside of the home if there are others living within the home. So it's a little complex. We are making headway on a clearer picture around how vast is the need. We do see that there is some need, and part of the need is about helping people understand how to access what public health has already put into place, and then adding to that capacity. So we're working through those details, Councillor Cressy. I'm sure early in the new year, we'll have a much clearer plan that we will be able to fully share. I think that includes just taking sort of quietly using the case management support, trying to expand and test out this expanded family approach model. The good news is the need doesn't appear as vast as we originally feared that it might be.
Okay, and so more to come early in the new year, work underway. One of the recommendations, we have the overarching equity action plan in front of us with the 10 thematic areas. One of the recs Denise spoke to specific and targeted Black and Indigenous streams of work, especially within the Black community where we've seen an exceptionally high disproportionate rate of infection. Can you just tell us what the next steps are on the specific Black and Indigenous related streams and when the board might hear back on them?
Of course, Councillor Cressy. So we certainly have been meeting with Black health leaders and community agencies to better understand some of the why and some of the patterns behind the data that, as you noted, continues to show very high disproportionate impact on Black communities. One of the things that's clear is that in addition to our larger equity strategy has been benefiting a number of communities, but there are some persistent issues within Black and Indigenous communities that require a much more nuanced and focused approach. We've presented a draft Black resilience and equity strategy, health equity strategy, to a number of Black health leaders last week. And we will need to do some more work to refine those approaches while we're simultaneously doing them. We're building cars as we drive them in this work, as we all know. And certainly one of the loudest and clearest voices or messages from the community, both Black and Indigenous, we've also met with Indigenous leaders to understand in that community from their perspective and to figure out how exactly we can support community-based efforts. And the thing that we're hearing very loudly and clearly, as we all know, the structural inequities that have just been worsened by COVID are longstanding, and that as we take immediate targeted actions, we need to keep our eye and our view and our commitment to pursuing the longer term structural responses as well. So we certainly are happy to come back and to continue to update Board of Health and to Council ultimately on the measures that we're taking both in the immediate and ultimately in the long term to address both anti-Black racism and anti-Indigenous racism that are playing a role in the moment we find ourselves.
Great. And then just with my last second here, one last question, and Eileen, this can go to you. The recommendation number 2 is for council and the board to approve the inclusion of equity indicators in our monitoring dashboard. So in other words, we have our healthcare indicators, our public health indicators, our case rate indicators. This is to embed equity as a core set of overarching indicators. So if everything's green but equity is red, then we're not doing well. And so I wonder what the status is of the development of those equity indicators and when we anticipate them being finalized and incorporated into the dashboard.
So thank you, Mr. Chair, for the question. We are working on that, and I understand that there are some, indicators that are being posed right now and being examined. I believe early in the new year, we should have something for the board to consider. And you're quite right. It is important to have those indicators in terms of evaluating our response. We do want to see inequities addressed, not only in respect of the COVID response, but on the go forward basis, as Denise rightfully pointed out. We don't want to see ourselves in a situation where we have programs that address things within the short term, only to have them fizzle or fade and not really address what are longer term consequences and longer term issues that are fundamental to the experience of health status in the city.
Thank you very much, Doctor. Okay, we're now going to move to a second round as requested by Councillor Wong-Tam. I'm going to put Councillor Wong-Tam down. Can I just see by a show of hands, is there anybody else who wishes to ask a question in the second round? Okay, Councillor Wong-Tam, over to you, and then we're going to move it in for speakers on this item. Councillor Wong-Tam.
Yeah, thank you, Chair. With respect to communities that have been disproportionately affected, and I think we've spoken quite a bit about who's actually not doing well during the pandemic. And sometimes it's in rather vague terms. So therefore, we know that Black, Indigenous, PLC communities, just people living with disabilities, are not doing well. So that has been captured, but the quantums of what categories that they need in terms of physical support, whether it's income, whether it's eviction prevention, whether it's childcare, it's sometimes difficult to extrapolate that into concrete, specific actions that are required. Who's doing who's carrying out the measurements of we need 1,000 units of new affordable housing? This is the corresponding response, and this is where we're getting it from. Can we flesh that out further? Just because I really feel some difficulty in capturing the exact requests that has to go to the federal, provincial government, or the responsibility of the city, whether it's childcare, whether it's income support. Can someone speak to that?
So perhaps I can start off with this, Councillor, and then I'll turn it over to Julie or to Denise. In the first instance, when it comes to specific situations, specific COVID-19 case situations, for example, that is part and parcel of the case management approach, to understand what the unique circumstances are of the individual, what's going on in their family, so that we can manage the COVID-19 infection as best as possible and prevent further spread to the greatest extent possible. So when it comes to COVID-19, it has to be done on an individual basis. I think when we talk about the needs writ large, because it's interesting that with individual COVID-19 cases, you're going to have to make it unique to the circumstances that you see. But when we talk about housing needs writ large, or who is at risk for who has food insecurity issues or housing insecurity issues, as communities or populations, these are managed in slightly different ways. And those will be undertaken by the kinds of assessments I believe Julie will speak to through our housing secretariat, through SDF&A, and through our colleagues at TEST. They have a good sense as to what is happening within the community writ large. So it's if it's specific to COVID, it may be very much linked to the case circumstances. Broader community needs are probably going to be managed through the assessments that are undertaken as part of our community assessment. I don't know if there's anything further, Julie or Denise, that you would care to add.
Thanks, Eileen. I think you've captured it well. Councillor Wong-Tam, I think you're aware each of our program areas continually monitors and assesses where the community's at and what the needs are. So, and that's one of the reasons behind our ask in the fall, earlier on in the fall, of the federal and provincial government to accelerate housing, that we needed 3,000 affordable supportive units over the next 24 months.
Yes,
and through the rapid housing program that the feds launched, that's been partially addressed. That'll get us kick-started. We do need more. We know on the child care front, we did a whole study in terms of what was needed in child care, so we know that we have to increase both the number of spaces and the affordability of child care. And we project that out not just based on current needs, but working with planning and understanding how the city is going to grow and change, and how our residents, what their needs are going to be looking into the future. And recreation, for example, does the same thing when we look at our recreation needs. So we're continually monitoring, and we're bringing that information together so that we can work across the city to put the plans in place to make sure that we can evolve and support the community appropriately.
And so do you believe confidently that we have provided the information to the other orders of government in a most succinct and quantitative way so that they can respond to it? And the reason I ask this question is because there's oftentimes some confusion and back and forth at perhaps the political level of what does the City of Toronto want? We've already made these announcements. We've given you more mental health dollars. We talked about it. And we've given you more housing dollars because we made an announcement about it. So how do we ensure that what we are asking for specifically is getting out in a response by way of the announcement from the other orders of government, but also there's some detailed tracking that you made an announcement, but that was nationally, and this is what the City of Toronto is actually getting. Just a small portion, and this is where you've fallen short, because there is some confusion, as I see it, that if the provincial government is sitting on perhaps, for example, $12 billion of unspent COVID emergency response dollars, and yet we've been asking them for COVID emergency response support, how is it that we're not getting to that?
And I'll back to staff, but Council, I'll just note we're at 6 minutes, so that was your final question.
That's it for me.
So I think the staff, and we work very closely with the intergovernmental office in the city manager's office, has been pretty clear in documenting our needs to the feds in the province. How they interpret that and how they flow the money is, I cannot speak to. I do know that we've been responding very quickly. We've had to, as I say, move at unprecedented speeds to make sure that we are able to support vulnerable communities. What we're going to have to pause and reflect on is we know how COVID is impacting vulnerable communities now. What we need to project is what is going to be the longer term effect. So as we move into recovery, my concern is that not all communities are going to recover at the same pace. So we're going to have to ensure that people that are housed don't lose their housing, that people that are now ready to return to work and have a job have access to affordable childcare. So we knew before COVID what that high-level need was, and we articulated that clearly. We have to revisit now and just keep a constant monitoring on the ground on what is happening so we can update those plans based on the longer-term impacts that COVID is going to have on some of our more vulnerable communities. And I think that work is being done, and we're working very closely, as I say, with the community agencies, because they are on the ground and they can help us really articulate and document that need. I don't know if Denise wants to augment.
No, Juliana, thank you.
Thank you to all of you. Thank you.
Thank you very much. So we're now going to move this into committee for speakers. So I'm just going to draw a speakers list here. By way of a show of hands, I just want to see who wishes to speak. Director Mulligan, thank you. Any other members of the board wish to speak? Councillor Lai. Anybody else on this item? Councillor Wong-Tam. And I'm just checking my other screen here. Okay, so we're going to go Director Mulligan, followed by Councillor Lai, followed by Councillor Wong-Tam, followed by myself. Director Mulligan, when you're ready.
Thanks, Chair. I just want to issue my strong support for all this work that has happened and for the recommendations going forward. Since the beginning of the pandemic, there are sort of 4 R's that I've been really interested in seeing move forward. Release data transparently that helps us inform and guide decisions when it comes to health and health equity. Take every possible action to help reduce people's contacts. Represent diverse communities and the expertise of community at decision-making tables, and provide resource community and community agencies to do this work. And I just want to say how happy I am that the City of Toronto, through public health, but right across the whole of government, has addressed all 4 of these. It's really what's needed to address inequities and to end the pandemic. And so it is really good to see. It's clear from the data and from the maps that we still have a lot of work to do to make this a reality, and that some of that work needs to continue to happen and grow at the city level, but also from the other levels of government. That we all need to be working together to make sure that we are on the same page about releasing data, reducing contacts, representing communities who have the knowledge and expertise to really make this happen for people who don't have a choice oftentimes in their level of risk exposure, and resource those community agencies, community health centers, and others to do this work. So I'm very pleased to see this. I would love to see this continue as an important equity direction for the city throughout COVID, but even more importantly, beyond COVID. These 4 R's are going to be critical as we encounter other health issues in what's really a syndemic, which is the combination of this COVID-19 pandemic, other health and social and economic and political conditions that have been distributed inequitably across our city for a long time. So thank you again for this hard work, and we'll keep pushing you to make sure it improves and grows over time.
Thank you very much, Director Mulligan. Next, I have Councillor Lai.
Thank you, Mr. Chair. Thank you, Mr. Chair. Like I said, this is going to be my last meeting at the Board of Health, and I just firstly and foremost, I'd like to thank you, Mr. Chair, for being such a good leader. And from the beginning, I've pushed on multi-language, and now without me even requesting it, you're making motions on council, including multi-language, because as everybody know, we really need to help those vulnerable communities, and we have to look for all of them and help all of them. And I'm very happy. And secondly, I'd like to thank the city staff, especially our deputy city manager. And you said it right on about we have to actually articulate and document our needs to the different levels of governments. And for you to work with the Toronto Public Health and Dr. Davila, you're doing a great job. And every day you are on CP24, we always heard you, and then you have a beautiful scarf every day. So, it's very, very good that everybody works hard for this, no doubt about that. And then I'd like to also thank the federal government and the provincial government for stepping up to help the city as well. And having said all that, I just wanted to ensure that everybody would be having a little bit of I guess this, because it's a second wave, we cannot really stop working hard. Everybody have to work hard. But having all said that, I wanted to wish everybody a happy New Year and happy holidays. Thank you.
Thank you very much, Councillor Lai, and thank you for your service on the board. Good luck on the TTC, where I know you are bringing your considerable time and efforts going forward. Councillor Wong-Tam.
Thank you very much, Chair, and thank you to staff for your ongoing work. And I want to just commend to those who have been on the leadership table of the City of Toronto, including the staff who are on the front lines. It is, of course, without precedent that you are all working hard to respond to this global pandemic. And much of it, of course, is without a blueprint. So you are assessing and you are quickly adapting the existing city programs and partnerships to actually scale up the response. And I don't think we could do it without the thoughtful, careful consideration and compassionate leadership that each and every single one of you have demonstrated so far. And there is no, there's always, of course, room for improvement. And I know that this is a group of leaders as well as a group of service providers that are always quickly adapting when they see a need or a gap that needs to be filled. And I really am very proud of that work, especially the work of Juliette Carbone, Dr. Davila, and everybody that falls under that leadership structure, including Denise Campbell. Really, we owe you a huge, enormous debt of thanks, including our city manager, our chair, and everyone else at the city who's really been driving this change. And we have on many occasions now, and I think for this city, quite eagerly, but also quite accurately describe the disproportionate impacts of COVID to certain communities. The level of frustration that I have is not necessarily resting with us and with the leadership at the Board of Health, none whatsoever here. I think the frustration that I have, and I think it needs to be stated, because we cannot necessarily let go of these reports without noting the fact that we're not getting the same type of corresponding support from the provincial government. Yes, the federal government is at the table, and we do know that they are responding, and they're trying to respond even sometimes without the leadership of the province. But healthcare and mental health care fall squarely within their purview. And so even though we are doing the best that we can with the attention with the provincial government, I cannot let another report go with respect to the impacts to equity groups be released from this board without citing the fact that we have an order of government that is not paying attention the way we need them to. Or if they are paying attention, they're not giving us the corresponding support that we are asking for. And I've asked in our meetings now in a whole number of ways, how else can we deeply engage with the province so that they can actually come to the table in winning conditions that will allow them to support the work that the City of Toronto is delivering. And in this report, which I think is important and groundbreaking, is a whole sort of identification of gaps, of things that are being asked for and the things that are missing. So when I speak about this matter, it is largely because I know that our staff will not be able to do their work without the resources and the funding and the support from the province. And so our efforts to address the health inequities will always be somewhat short until the province comes to the table. And that's why I feel and I believe it's important for us to continue to cite that until they actually arrive at the table with the supports in hand, with the long-term sustainable funding commitments in hand, without a one-time expiry date in March, or perhaps an announcement that is vague on details, only to have details be released weeks later, where all of a sudden we're into a new crisis or a new phase of crisis that now has even further amplified and magnified itself. So, Mr. Chair, I know that you'll be moving a motion that will be largely supported by the Board of Health members. We thank you for your ongoing leadership and deep engagement with us. And I just want to associate myself with the motion that you're going to be tabling and lend you my full support. Thank you very much, everyone.
Thank you very much, Councillor Wong-Tam. Let me just do a final call for any other speakers on this item. Okay, seeing none, I'm going to put myself on. So first, let me begin by noting that the staff recommendations in front of us, of course, I will move, which is to endorse Toronto's Equity Action Plan for the city and the board, to approve the inclusion of equity indicators in TPH's monitoring dashboard, and to embed the Equity Action Plan and its work, not only in our response, but in our recovery. And I would move an amendment that has been pre-circulated as well, which if our clerks can put it on the screen, I will speak very briefly. This amendment first requests our staff and the medical officer of health to report back on the status of the implementation of the Equity Action Plan, including the specific streams of work that staff are working on targeted at Black communities within the, Toronto, of the Black community, the Indigenous community, and the disabled community, as well to continue the work that is ongoing around family isolation, for the board to endorse the recently announced enhanced measures by the TTC to expand physical distancing in disproportionately affected neighborhoods and to encourage the TTC to continue to scale up that work. And finally, on sick leave, and I'll be specific here, time and time again, going right back to the spring, this board and city council have called on the other levels of government to implement adequate sick leave during COVID. But time and time again, other levels of government who have responsibility for this have not. And this request here is, I think, in part to better drive the city and the board's advocacy and our attempt to solve this issue by requesting staff to report back in January on the specific sick leave options available to the other levels of government, whether that's a temporary provision under the Employment Standards Act or the expansion to include sick leave under emergency assistance, so that we can be targeted and specific in our calls and advocacy in our attempt to solve the gap in sick leave. So those are the amendments that I have placed along with moving the staff recommendations. Let me begin by having spoken to those amendments by thanking our staff, both in Toronto Public Health for their unwavering commitment to address inequities as part of our COVID response. But I really want to acknowledge and commend here as well Deputy Manager Juliana Carboni, Deputy City Manager, Denise Andrea Campbell, the Executive Director of SDFA, and the whole government at the City of Toronto for their response. This is a whole of government response to equity. It's not the responsibility of SDFA, it's not the responsibility of TPH, it's the responsibility of each and every division within our city to embed equity in our response. So I want to thank staff for that, and I want to acknowledge and note this board, each and every one of you, and if you could forgive me for singling out Director Mulligan and Councillor Wong Tam, for their push and drive to ensure that equity was at the heart of this response. COVID didn't create the housing crisis in our city. It didn't create the rise of precarious work or structural racism, but as we know, it has exposed and exacerbated them. And we cannot, as we've talked about, beat COVID without tackling structural inequity. And so you can't tell somebody to go and get a test and isolate if the result of a positive test is the loss of a paycheck, which could result in the loss of their home. That's why we need sick days and eviction moratorium. You can't tell someone to isolate if they can't do so safely, which speaks to isolation facilities. And so whether it's transit to enable distancing, whether it's testing to make it accessible, whether it's outreach, community-based resourced outreach to address hesitancy, or whether it's policies like sick leave and income assistance or eviction moratorium, an equity-driven response is not the responsibility of one agency or one department. It is the responsibility of every facet of every order of government. And so on that front, and I would echo Director Mulligan's comments, I'm proud of the work this board and this city are doing, and there's many firsts. The first to collect and share disaggregated data, the first to drive some of those responses like isolation facilities, the first to develop and endorse an equity plan. But here's the thing, when you're dealing with structural inequities, you don't get a medal because you do good work. You don't get a pat on the back because you do good work. You do more good work because that's what's needed. And so we, in the days, weeks, and months ahead, in the midst of a devastating second wave that I deeply am concerned will replicate the outcomes of the first wave, we need to fight with everything we've got at the city, and we need to fight with everything we've got to ensure that the provincial and federal governments do the same to protect those who are hardest hit. And I will tell you that I'm actually, despite the great optimism and the scientific success with the development of a vaccine, I'm concerned that the vaccine will result in governments turning their focus away from the continued disproportionate and brutal assault this pandemic is waging on frontline workers, on racialized Torontonians. I'm concerned that the focus is going to turn straight to a vaccine and in turn might abandon them in this hour of need. And so we must seize this moment, not just to roll out a vaccination campaign that targets everyone, but also to continue to protect everyone with an equity-driven response. Thank you very much. With that, I would suggest that we take this as a package, the amendments as well as the staff recommendations. Can I just see is anybody uncomfortable with that approach? Seeing none. Okay, to our clerks, we have taken as a package the amendments as well as the staff recommendations. All those in favor? Opposed, if any? Thank you. Members of the board, that is the first centrally embedded equity action plan in the country. Kudos to staff and you. We will now turn to our second item, item HL 24.2, response to COVID update. If you thought we just dealt with COVID, there is more to come. We will begin with a presentation from our Medical Officer of Health, Sarah Collier, and Liz Corson from TPH as well. We will then turn to hear from one registered speaker before bringing it back into committee. So Dr. Davila, we speak all the time, but back over to you.
We do indeed, Mr. Chair. Thank you very much. I will in fact be turning it over to my colleagues, Sarah Collier and Liz Corson. They are much closer to the data in respect of COVID-19, and if I can, while there are the two of them here who are going to present the first part of this presentation, I know that they work with a number of other colleagues back at Toronto Public Health, and they are really doing Herculean work in respect of the response. One, to make sure that we are informed as Toronto Public Health. Two, that you are informed as the Board of Health. And three, and perhaps most importantly, the role is to ensure that these data are being applied to achieve the key objectives of the response and to address the health status issues and the inequity issues that we've just been speaking of. So without further delay, I will hand it over to Sarah and Liz, who will take us through the first component of the presentation, and then I'll close off the end.
Thank you, Dr. Davila. Can I just get a thumbs up that you can hear me okay? Okay, great. Thank you. Good morning. Thank you for the opportunity to present. Today, I'm going to provide an update on the epidemiology and surveillance of COVID-19 in our city. I'll be discussing a few of the key indicators we continue to monitor, many in the context of the 28-day lockdown. My colleague Liz Corson, who is a supervisor on the epidemiology and data analytics unit, will be taking over for the second part of the epidemiology report. I am incredibly grateful to have Liz on the team, and I'm very happy to have her here today. She's going to walk you through some new findings on our work on the equity metrics, mental health, and behaviors related to the pandemic. So next slide, please. I'm going to start us off with this updated version of this infographic. You have seen this many times before, and this is to share the most current totals and key COVID metrics. So as of yesterday at 2 p.m., we had a total reported case count reach 49,236 since the beginning of the pandemic. So that is a 40% increase, which translates to just over 14,000 additional cases since we reported to you at the last Board of Health meeting last month. And I'm not going to take too much time going through all of these metrics, but I did want to point out that we are unfortunately seeing an increase in those currently in hospital, and I'm going to be diving into that in a later slide. Next slide, please. So this slide has a lot going on, and I'm going to try and walk you through it, and I'll try to just highlight some of the key points. There are two panels, so there's the top panel and the bottom panel. Along the bottom is the date, so we're starting at October 1st, and so really we're looking at the second wave in this panel. The top section is showing the cases in the gray bars, and the blue band is the date that we estimate that cases were infected. So what we can see in this first graph at the top is that there are bumps or increases in infections, and then there is a bump in the increases of cases reported to us. So there's this delay between when a person becomes infected and when they show up as a case, and we've known this for a long time. We use this information to help us inform the bottom panel. And the bottom panel is showing the effective reproductive number. So the effective reproductive number, which I'll refer to as RT, represents the average number of people who are being infected by an infectious individual at a specific time. So the RT is affected by the number of people in the population that are infected and the number of susceptible individuals with whom the infected case is in contact with. So when the RT is above 1, the virus spread grows. And when the case numbers are high, like we're seeing right now, those numbers can really start to climb. And when the RT is below 1, the virus spread declines. And that dotted horizontal line in that second panel represents an RT of 1. And so I want to draw your eye to the RT through August to the beginning of September. It's hovering well above 1. And then gradually we see that impact on the top panel on our case numbers. So we were successful, if we're going back to the bottom panel, we were successful at the end of September in driving that RT down. But with cases high, unless we get it below 1, we're going to see this continued high and growing case count. So the reason why we model the RT at the time of infection is because it's actually it's better at seeing the changes that can be associated with changes in policies. So we can see at the bottom panel, again, thinking about that 28-day lockdown, that for infections that were acquired on December 1st, we observed an RT of 1.1, which means that the virus is still spreading and growing. I know that we're all eager to see some positive impacts of the lockdown, but based on modeling this pandemic for several months now and through various policy changes, we know that it takes approximately 4 weeks to see the impact of public health interventions on RT. And then it takes a bit more time before those cases are reported to us and show up in our data and our monitoring indicators. So in other words, if I were to summarize this entire slide, it really is that we're going to need to check back in the beginning of January to see if there was a decrease in cases. And we are very hopeful. And we, of course, continue to monitor the RT to see if we will start to see it dip below 1. Again, indicating that there is a slow decrease in cases ahead of us. But based on our current RT of 1.1, again, we can expect to see an increase in cases. So we have also been looking for indicators that are more immediate, that can give us a glimpse into how non-pharmaceutical interventions may be impacting behavior in the population that may reduce the degree of contact between people and therefore result eventually in a lower RT. So moving on to the next slide. Toronto Public Health has recently obtained aggregated and anonymized mobility data. So these are not individual records, but rather show the population trends overall. These aggregated mobile device data come from users who have authorized sharing their location in apps, so mapping apps, weather apps, social media, for example. And the data are collected on the location of the device every 30 minutes, and then again aggregated and sent to us. So this figure shows the weekly proportion of mobile device time spent at home for Toronto between January 1st and December 5th. So over the span of an entire year and the pandemic. So this is the proportion of time a device spends within 200 meters of its home location in a 24-hour day period. So when the proportion of device time is high, at home is high, we assume that people are spending less time moving around and possibly less time interacting with others. Again, it's a proxy. And so what we can see in this graph is that after the initial lockdown in March, Toronto saw a rise in device time spent at home. In other words, less time spent outside of the home and less mobility, to a high of about 86% of device time at home. This proportion gradually dropped throughout the stages of reopening, with a low of approximately 81% of device time spent at home at the end of August. Since September, we have seen a very slight increase in proportion of device check-ins happening at home. And while it is still higher than what we were seeing in February before the first lockdown, it is not close to the levels we were seeing in March. So next slide, please. As I mentioned before, we are interested in seeing if this lockdown will have an impact on the case numbers, but we also need to continue to monitor other indicators as a means of understanding what the current high case count will mean for hospitalizations. as well as our ability to test and trace. So we continue to encourage folks to check our monitoring dashboard. We update this 3 times a week in order to have an up-to-date understanding of the trends. Next slide, please. Focusing on this virus spread and containment section of the dashboard, we can see that there is a pattern of increase in all of our indicators here. I've specifically highlighted in the bottom part of this slide the numbers that we would need to see to move us from red to yellow or from yellow to green in the case of the RT. So in order to move our 7-day moving average of new COVID-19 cases to yellow, we would of course be looking for a 14-day increase in cases, or for our cases to get to 293 new cases per day. And this is information currently from our monitoring dashboard, which was updated Friday, and we are currently at 422 new cases per day. And that's, again, a 7-day moving average. In the interest of time, I just want to focus on the trends in new hospitalizations because it's also concerning. While we're reporting approximately 15 new cases hospitalized per day, we know that there is a delay in when hospitalizations are reported to us. So that very sharp line down at the very end of this line is likely just due to a reporting lag. And so I just want to talk a little bit more about hospitalizations. So if we could move to the next slide. This graph is looking at 7-day moving average of new hospitalizations, and that's that dark blue line. And here we've adjusted for lag time. So we've accounted for 3 days of lag time in the hospitalization becoming known to Toronto Public Health. So on December 9th, we had 24 new hospitalizations. We've also graphed the total number currently in hospital, again, that have been reported to Toronto Public Health, and this is the light blue shaded area. And what we're seeing here is that the pattern seems to be that approximately 10 days to 2 weeks after the peak in new hospitalized cases, so again, those being newly admitted each day, we see a reflected peak in the cases currently hospitalized. So those total COVID cases in hospital. And again, using that 7-day moving average, so a bit of a different metric than the infographic I shared at the beginning of the presentation. As of yesterday at 2 p.m., we have approximately 307 people being reported to Toronto Public Health as currently hospitalized for COVID-19. This is a 36% increase in the 7-day moving average of those in hospital over the most recent 4 weeks. I do want to note that hospitalization is a delayed indicator, and this means that we really only see these increases and these peaks after the increases in cases. Moving to the next slide. So I just want to switch gears a little bit to look at another way to look at patterns that relate to the virus. And so here is a heat map of age groups. The age groups are along the left-hand side, and a specific percent positivity across time. And we have shown this graph before, and it is available publicly on our public dashboard. And what this is showing is where the color is darker, the percent positivity is higher. And the main trend this shows us is that all age groups have seen an increase in percent positivity since August when we started receiving this information. But what you may be noticing is that if you look at the darkest blue, those darkest colors in the most recent period are for those aged 14 to 17 years of age and 18 to 23. Most notably, the percent positivity for secondary school age children, so again, that's the 14 to 17-year-old age group, is 11.6 for the most recent week of complete data. Now, just with any other indicator, this information is important to consider in the context of other indicators. So I'd like to move to the next slide, please. So if we take a look at this graph, this is looking at trends of COVID-19 case rates across age groups. And we're looking here at cases with episode dates between August 1st and December 5th. And again, this is in the second wave. So this graph is really going to illustrate a few important points. One, case rates are increasing in all age groups. Case rates for COVID-19 in elementary school age children, so that's the 4 to 13 years, which is that orange line, continue the upward trend we have observed since mid-August. However, they are currently lower than the case rates in the two largest adult age groups, so between 18 and 69 years of age. But I do want to note that the gap between elementary school age and adult age group case rates continues to narrow. I'd also like to highlight that case rates in secondary school age children, so that's the 14 to 17-year-olds, and that's the red line in this graph, it appears to have had a rather steep incline in October, but possibly we're seeing a bit of a plateau in the last 4 weeks. And we can see that the case rate in that 14 to 17-year-old age group is similar to the adult case rates. Next slide, please. So as we saw in the last slide, there has been an increase in cases in children. This is an epi curve of cases in children aged 4 to 17, so that's school age, by week. And it's broken down by those that are linked to an outbreak and those that are sporadic. And we can see that only a proportion of those child cases are linked to an outbreak. Since September 15th, when schools opened, 18% of cases in children aged 4 to 17 have been linked to an outbreak. We can see in this graph that those linked to an outbreak has increased slightly since in November. And we can see, and this is because we know that we have seen an increase in the number of outbreaks in schools since the beginning of November. I want to note that we have over 1,100 schools currently operating in person in Toronto. As of yesterday at 2 p.m., we have seen 122 confirmed outbreaks in schools since the beginning of the pandemic. Currently, there are 38 active confirmed outbreaks in schools. While there have been a few outbreaks in schools with large numbers of cases, the average number of cases per confirmed school outbreak has been 4.8 cases. Next slide, please. I would like to mention something positive. I often have to bring relatively negative information to this board, and so I'd like to take a moment to highlight this map. We've presented many maps to the board before, and we've discussed this in the last agenda item, but while testing rates in some parts of the city, especially the Northwest, have continually had testing rates below the city average, we are now seeing a shift to testing rates that are well above the median. And I know that there have been many groups working to improve the testing in these areas, and I think that this map is beginning to show some of that progress. And so I wanted to bring it here today as a tiny bit of a good news story. Unfortunately, case rates and percent positivity continue to increase across the entire city, and while the testing rates can be seen as a small win, we know that COVID-19 is not impacting the city equally. With TO supports, our equity action plan having just been discussed, we thought it prudent to bring forward our newest data on these disparities. And I'd like to take a moment now just to turn it over to Liz Corson, who's going to take you through some of this work.
Thank you, Sarah. Next slide, please. Perfect. So as you've heard before, our data show that people who are living with a lower income and people who are racialized are overrepresented in our reported COVID-19 infection rates. As Juliana mentioned this morning, some of the factors contributing to these inequities likely include pre-existing health, social, and economic disparities, systemic racism and other discrimination, higher likelihood of being an essential worker or living in housing or using transportation where physical distancing is difficult, and a lack of access to health and social services. Today, we're showing you an update on these data looking at trends over time. This graph shows the rate ratio for each of our ethno-racial groups by month up to October 31st. The rate ratios compare the rate in each ethno-racial group to the rate in the rest of the population. If a rate ratio is larger than 1, and that's the gray horizontal bar on the graph, it means that a particular group is overrepresented in COVID-19 cases. And if it's less than 1, they're underrepresented. Ethno-racial groups that are consistently overrepresented include Arab, Middle Eastern, or West Asian people, Black people, Latin American people, South Asian or Indo-Caribbean people, and Southeast Asian people. There have been fluctuations in the relative distribution of these racial groups over time. Black people had a very high rate ratio over the summer, and while they're still overrepresented, their share of COVID-19 cases in relation to other ethno-racial groups has decreased a bit in the fall. That's shown on the orange line. Latin American people, who were greatly overrepresented at the beginning of the summer, but then saw a bit of a decrease in their rate ratio, have increased again and now have the highest rate ratio out of all of the ethno-racial groups in October, and that's the light blue line on the graph. Also increasing in their share of cases is the South Asian and Indo-Caribbean group, that's the green line. It's important to note that while the rate ratio fluctuates over time, the true rate for all of the ethno-racial groups has increased in October. So for example, despite the rate ratio dropping over the last few months for Black people, the overall rate in that population has increased along with the rate in the entire population. I also just want to re-emphasize that racialized people are more likely to be essential workers and face precarious employment, precarious housing, and transportation challenges, and that these are likely the driving factors behind the higher rates in these communities. Next slide, please. We're also still seeing disparities in household income groups over time. This graph is showing the rate ratio of reported COVID-19 infection by household income group. So groups that have a rate ratio above 1, again, the gray line across the middle of the graph, have a higher rate compared to the rest of the population. The inequity by income was a bit higher in the beginning of the summer than it is now, but it's still striking how the lower household income groups bear a greater burden of reported COVID-19 infection due to a lack of access to the social determinants of health and barriers to participating in the public health response to COVID-19. Next slide, please. To ensure that we remain committed to reducing these inequities, we're introducing a new layer of indicators to our monitoring dashboard. As Councillor Cressy mentioned earlier this morning, these indicators will provide a high-level glimpse into whether or not our response to COVID-19 is contributing to a reduction in inequities. And it will ensure that we factor trends in inequities into decision-making that affects the whole city. We plan to add 3 regularly updated indicators to assess this, and we're leaning towards using rate ratios, similar to what I've just shared with you, to compare the highest and lowest groups for reported COVID-19 infection across neighborhood, ethno-racial identity groups, and income. The detailed information that can inform action to reduce inequities is already available on our COVID-19 status website, like, for example, the graphs I just shared and our neighborhood maps. But these additional indicators will provide a high-level marker upon which to evaluate the success of our equity action plan. And just to respond a bit further to Councillor Mulligan's question from earlier this morning about evaluating the equity action plan, there's also work underway to develop surveys for community partner agencies to complete on a regular basis that will assess some of the outputs of the strategy, and also client satisfaction surveys that can assess some of the outcomes of the equity action. Our next steps on the equity metrics for the monitoring dashboard are to consult partners in community agencies and advocacy groups to inform the details of these indicators, and to make sure that they're supportive and reflect community experiences, that they can inform constructive action, and that they don't stigmatize or cause harm. We're going to be reaching out through the city's community cluster tables about this consultation shortly. Next slide, please. We've just touched on some evidence that suggests that some of the, next slide, please. Perfect, thank you. We've just touched on some evidence, sorry, maybe there's a bit of delay on my feed here. We've just touched on some evidence that suggests that some of the public health measures put in place to reduce COVID-19 infection are only effective in certain neighborhoods. And now we're going to move to another unintended consequence of these measures, and that's their contribution to a negative trend in mental health. As presented to you on November 16th, mental health and addictions-related help seeking in the emergency department decreased during the first wave of COVID-19, and help seeking from virtual and telephone support, including crisis lines, increased. A summary of this evidence from the first wave of the pandemic is presented as an attachment to this month's report. This report shows that during the first wave of COVID-19, a greater percentage of calls to virtual and telephone supports, for example, 211, shown in the graph here, were for mental health assessment and treatment compared to before the pandemic. Other service providers also saw an increase in calls for isolation as well. A lower proportion of people reached out for substance use and disorder services, and one hypothesis for this trend is that a lot of services were closed during the first lockdown, which has likely exacerbated the drug poisoning crisis in Toronto as well. We're updating this report with more recent data, and we'll be reporting back to the board in the new year with the findings, but some preliminary analyses suggest that we might be seeing a repeat of what we saw in the first wave, whereby mental health ED visits decreased in the COVID resurgence, which might mean another increase in calls to community-level virtual and telephone support. Next slide, please. Toronto residents are reminded that they have access to free mental health services from the safety of their homes. Anyone experiencing anxiety or stress can call 211 to connect with one of the 13 mental health service providers for direct phone support. Next slide, please. As we mentioned at the last meeting as well, we've also received some information on the mental health of Torontonians via a sample of 1,201 poll panel participants from the online Ipsos-administered TPH COVID-19 community survey. At the last meeting, we shared with you that at the end of October, 33% of Torontonians considered their mental health to be much or slightly worse than in March. Here we're showing that at the end of October, 29%, almost 1 in 3 residents, consider their mental health to be poor or fair. While 36% consider it to be excellent or very good, normally over 70% of adults consider their mental health to be excellent or very good, based on the Canadian Community Health Survey for Toronto. Over the past 10 years of available data, the percent of adults who rate their mental health as excellent or very good has not dropped below 70% until COVID hit, and now it's 36%. Next slide. So why is people's mental health suffering? There are a lot of reasons, and many people in our city are experiencing many of them. Anxiety about the pandemic is an obvious reason. 66% of people are anxious about their health, and 49% are worried about job loss and financial security. 69% were anxious about another lockdown, and this survey was conducted at the end of October, so before our current gray reality in Toronto. And 77% of people with kids are worried about the impact of COVID on their children's education. Poor mental health is also likely being driven in part by the fact that many Torontonians are now getting less physical activity. 42% are saying they're getting less physical activity, and 33% are getting lower quality sleep than before mid-March. The pandemic has caused a net negative impact on both. The concept of pandemic fatigue is also real in our city. 39% of people are frustrated with the restrictions on their personal freedoms, and 46% are tired of taking precautions and want to get on with their lives. Next slide, please. Despite people's frustrations with the pandemic, and despite many of their other mental health concerns, people are still, for the most part, complying with the public health measures put in place. Mask wearing is now a widespread habit, and nearly all residents, 97%, wear one at least in indoor public places. Overall, 90% of Toronto residents agree that the city needs to take whatever measures are necessary to control the spread of COVID-19 and reduce the number of deaths. There was also widespread support in October, over 80%, for a second lockdown if the number of cases continued to rise, which they did. But people are conflicted. 42% agree that strict public health measures like lockdowns do more harm than good. And 39% say we should allow businesses to open or operate as they choose, even if it means COVID-19 cases in the community can increase. This might be driven by the fact that Torontonians recognize that COVID-19 is a threat, but many tend to see it as something that happens to other people. While 64% see the virus as a risk to Toronto, only 32% see it as a personal risk to themselves. There's also a widespread perception that in many cases, COVID-19 is manageable. Only 24% of Torontonians think that they would get extremely sick or very sick if they were to get the virus. I just want to take a quick second here to point out some of the limitations with these data that we're presenting from the Ipsos poll. First off, as with any poll, the questions were asked to people who have signed up to be on a panel to answer poll questions, and participation is incentivized. Second, as it was an online survey, people with limited access to the internet and digital technology would likely not have participated. So we just have to consider these potential biases when we interpret the data and understand that there might be some variation in the true proportions of some of these things in the broader population. Next slide, please. The last topic from the Ipsos poll that we're touching on today is vaccination, obviously a very timely topic. Once a COVID-19 vaccine is rolled out in Canada, a majority of Toronto residents, almost 3/4, say they're likely to get it. This leaves 1/4 who either don't plan to get it or aren't sure yet. Of those who would not get the vaccine, 36% were concerned about the side effects or don't trust it. 26% were concerned about its safety because it was rushed or there wasn't enough testing to prove the safety, and 6% were against vaccines in general. The good news is around 85% of Torontonians trust the information provided by medical and scientific experts and express confidence in Dr. Davila to keep them informed. So there is hope for convincing some of those who think they'll probably not get it or that they don't know that they actually should get it. And with that vote of confidence, I'll pass it over to Dr. Davila, who will update you on preparing to roll out the vaccination.
Thank you, Liz, and thank you, Sarah. Again, if anyone has my vote of confidence, it's certainly you two and the entire data team at Toronto Public Health. As you can see, we have some very skilled individuals working for us and working on behalf of the people of Toronto. So turning now on preparations for the COVID-19 vaccine, you've probably heard quite a bit about this. It has been the subject of much media coverage as of late. You know, I'm sure that Health Canada has approved the first COVID-19 vaccine for use in Canada. And I believe there were just reports coming in about its arrival. And there's much fanfare and excitement, as you can well imagine, as this vaccine is starting to make its way here into Ontario and specifically into Toronto. We are expecting in Canada to receive just under 250,000 doses of vaccine by the end of the year. And at a very high level, while you know, our provincial counterparts are largely responsible for the distribution and for prioritizing and setting up the parameters for the vaccine campaign, we are of course engaging with them, as this is an area, a subject matter with which we're familiar. This being said, the plan is in accordance with federal guidance and as articulated by the province. Certain subpopulations identified by the province will be the focus for the first lots or allocations of vaccine, and it will likely be at some point in the spring before you start to see wider population access to vaccine. You've heard a little bit about what we understand based on surveys as to the interest or, you know, and the plans of our population around taking up vaccine. But of course, we have every intention of working with community organizations, and that work has already started, to be clear, to create a vaccination campaign that actually focuses on the community and its needs. And we're really interested in ensuring that the broad diversity of populations here in the city of Toronto are not only knowledgeable around the vaccine and its benefits, but are really engaged in the planning of the COVID-19 immunization efforts so that we can ensure that the vaccine is able to deliver on its promise. The vaccine is only as good or as effective as it is taken up by a significant proportion of the population. So that's certainly an important component of our COVID-19 response and is the latest addition, if you will, to our overall activities as part of the COVID-19 response. Let's turn now to the next slide, please. Focusing now on the issue of workplace outbreaks. As you know, right now, Toronto Public Health releases information about workplace outbreaks when there's a need to notify the public of a potential exposure. And at the September board meeting, a request was made specifically of me and the team at Toronto Public Health to implement a system for more public disclosure in respect of workplace outbreaks. So we are now in a position where we're working on posting workplace outbreak data by category, you know, in the coming week. This is something that we have been working on since having received the request from the Board of Health back in September. And what we're proposing right now is a system by which to engage in this disclosure, similar to the system that has been introduced in recent weeks by other colleague health units, notably our colleagues in Ottawa, in Peel, and in Waterloo. And on an ongoing basis, where there is a public health risk, clearly, as we have always done, we will continue to post information about those workplaces by name in order that members of the public are aware of potential exposure risks and can take the necessary action in order to control or reduce that risk. There is ongoing work on the potential for provision of greater detail in respect of workplace outbreaks. This work is still underway, and I have to admit is a little more challenging right now than might normally be the case. One of the major issues that we have in front of us at this point is that we are just in the process of switching over to a new information management system that actually is the method by which we collect, store, and manage data in respect of COVID-19 cases and outbreaks and clusters and the like. And as we are making this switch, we want to make sure that when we are reporting on information, particularly when we're talking about new reporting and disclosure mechanisms, we want to make sure that we have all the issues worked out appropriately so that we are reporting in a fashion that respects privacy requirements as per the board's direction, but as well reflects the real situation. We want to make sure that we've got accurate information that's being put out there so that it is valid and can be used in the way that we intend it to be used to control public health risk. Next slide. But we all know that with respect to workplace outbreaks, disclosure is not the end in and of itself. And on the contrary, the objective is to make sure that we're supporting the ability of our public to engage in appropriate self-protective behaviors and in for employers as members of the public to also ensure that they are facilitated to engage in appropriate behaviors that creates for safer workplaces amongst the many places in our community that need to be made as safe as possible while we are continuing to live with COVID-19 in our midst. Hence, we have spent quite a bit of time working with our colleagues at the Ministry of Labour Training and Skills Development, not only in terms of advocacy, as they really have the purview over workplaces, but we've actually been working with them in very concrete and action-oriented ways in order that we get effective change happening within workplaces. So one of our associate medical officers of health at Toronto Public Health is in regular communications with an ADM level person at the Ministry of Labour Training and Skills Development. We are actively participating. We're doing joint inspections of workplaces and ensuring that we're speaking the same language. I will say this, Ministry of Labour tends to come into a workplace with a slightly different perspective relative to that which we have in public health. We're bringing them more to what I would characterize as a public health approach, a prevention approach that really does take into consideration the best available science, including behavioral science, so that we're creating environments that allow for people to protect themselves and protect others around them within their workplaces, and seeks to actually get the kind of compliance and adherence to public health practice that we're looking for, not only from the workers themselves, but most importantly, from those who are responsible for those workplaces. That's really what will create the safest workplaces possible while we're working on the disclosure elements of the toolkit as well. So turning now to the next slide, let's look at the just high-level summary on the report recommendations. You'll see here on this slide that there are a number of recommendations made within the report that get at the significance of the COVID-19 response and really seek to ensure that we have the available resources, or the necessary resources and funding, I should say, to effect a proper response. And in particular, we're talking about supporting a good rollout of immunization as the latest dimension, if you will, of the COVID-19 response. We need these resources and funding to be in place to support a proper COVID-19 immunization plan and its implementation, so that as a community, we can actually maximize the benefit of really what is a remarkable development from identification of virus in January of this year to the rollout of vaccine and its actual administration by December of the same year is an absolutely unprecedented achievement of science and of collaboration amongst key partners. And I don't think we can emphasize how significant, emphasize enough how significant an achievement that is. And if we are to capitalize on the significance of that achievement and to maximize its benefit, we need to make sure we have the appropriate resources and funding to actually take advantage of this remarkable development.
Dr.
Turning
Davila,
to the next slide.
I'm gonna ask you to take us through the next couple slides quickly, just on account
Sure.
of time.
Sorry, Mr. Chair, I'm just about done. We're almost at the end. Last couple of recommendations you'll see on this slide and actually on the next as well, which is the final slide. It speaks to the need for data and collection and the sharing of these data and the use of these data for the appropriate and evidence-informed action that's necessary to respond to COVID-19 and ultimately to improve health and reduce inequities in the experience of health and the experience of the COVID-19 pandemic in particular. So with that, actually, Mr. Chair, that is the end of the presentation. Thank you for your patience. And of course, we are happy to take any questions that you may have.
Well, thank you very much, Dr. Davila, Sarah, and Liz, for the exceptional work under the most trying of conditions. Exceptional, thank you. We have one registered speaker, so we're going to turn to hear from our registered deputant before bringing it back into committee for questions. I'll check with our recording secretary. Do we have Derek Morin on the line?
Hi, can you guys hear me?
Derek, we can hear you. You have joined us before, so you know the drill. You'll have 5 minutes when you're ready. Please go ahead, Derek.
I just want to say, by me speaking at this meeting, this shall not be deemed to be in any way my consent expressed or implied, and doing so is fraud. God bless Her Majesty the Queen, and long live Her Majesty the Queen. And by the way, I heard on this season's second episode of Grey's Anatomy, one doctor say to her two colleagues talking about COVID-19 that nothing's credible until it's being peer-reviewed and published. So one of the questions in this survey was about whether one has confidence in Dr. Davila. I just want to point out, I recently emailed City Solicitor Wendy Wahlberg that Scott Duncan has said that by way of her title credential of doctor, that Dr. Eileen Davila is surety for everything she signs and everything she says, and asked Wendy if that was true. To date, Wendy Wahlberg has yet to respond to my email. Because one thing I've heard Dr. Davila say a number of times is that her best health advice is guided partly by experiences from other jurisdictions. So I wanted to share with her a recent experience from another jurisdiction she may not be aware of, from a recent court decision dated November 11th, 2020, where a Portuguese appeal court ruled against the Azores Regional Health Authority. If you're looking at my written submission, I provide links to the article from Portugal about the court case, the actual ruling in Portuguese, and the English translation of it. In this case, the court said the identification of a disorder, disease, or the state of a disease by studying its symptoms and signs and analyzing the tests performed is a basic health procedure that must be performed by a doctor, and in each specific area by a specialist doctor, and aims to establish the best preventative, surgical, pharmacological, non-pharmacological, or rehabilitation therapy. It is thus clear that the prescription of auxiliary diagnostic methods, as is the case with tests for the detection of viral infection, as well as the diagnosis of the existence of a disease in relation to any and all people, is a matter that cannot be carried out by law, resolution, decree, regulation, or any other normative way, as these are acts that our legal system reserves to the exclusive competence of a doctor, being sure that in advising his patient, he should always try to obtain their informed consent. In the case we're dealing with, there is no indication or evidence that such a diagnosis was actually carried out by a professional qualified under the law and who acted in accordance with good medical practices. Indeed, what follows from the facts taken for granted is that none of the applicants was even seen by a doctor, which is frankly inexplicable given the alleged seriousness of the infection. It also violates number 1 of Article 6 of the Universal Declaration on Bioethics and Human Rights, which Portugal subscribed to and is internally and externally obliged to respect, since no document proving that the informed consent that this declaration imposes has been shown in the file. Now, all of this has me thinking, when Dr. Davila speaks twice a week at those briefing sessions and says, for example, today I am reporting 553 new cases of COVID-19. So for greater certainty, is she reporting on new cases that were as a result of a laboratory test, or is she reporting on new cases that were as a result of a medical diagnosis that was performed by an actual doctor? And I respectfully direct you, Councillor Cressy, to ask Dr. Davila to answer my question.
Very much, Derek. Are there any questions for Derek?
No. Councillor Cressy, I respectfully direct you to get Dr. Davila to answer my question.
Thank you, Derek. This is the opportunity for members of the public to speak to us. And that's what you're doing. It's not an opportunity for you to ask us questions. So thank you very much.
No,
just caucus. Are there any questions for Derek from members of the board? Okay, seeing none. Thank you very much, Derek. Appreciate it. Okay, to our recording secretary, are there any other members of the public who have registered to depute? Sorry, Julie, I can't hear you there.
Sorry about that, Mr. Chair. I can confirm that there are no further public speakers on this item.
Okay, thank you. So at that point, we're going to move this into committee. And with thanks again to Liz, Sarah, and Eileen for the exceptional and comprehensive presentation. Let me open it up. Members of the committee who have questions for our team. I see Trustee Donaldson, and Director Sue Wong. Other members of the committee? I'm going to check my other page here.
She may resign, and it's be unfortunate.
Councillor Lai, please.
Councillor Lai,
where we are in the process.
thank you. I would just note that Chief Pegg of the Daily Media Availability fame has also joined us. I see him on the screen. That's just a shout out because I like to do that. No questions from Chief Pegg, just a hand wave. Are there any other members of the board who have questions? I have Trustee Donaldson, followed by Director Sue Wong and Councillor Lai. Okay, we're going to kick this off. Trustee Donaldson, when you're ready.
Thank you, through you, Chair. Thanks so much for this report to Sarah Collier and Liz Corson in particular. You have a way of making extremely complex information very understandable. So kudos to you for your ability to do that and all the amazing work that you do. I was surprised to hear that only 32% of those surveyed see COVID as a risk to themselves. That's pretty low number. And it made me recall last year the vaccine strategy that Dr. Davila, you brought to this board. And in that, I think I recall you saying that the estimate is 20% of the population are already vaccine hesitant. So my first question is there any evidence over the course of this pandemic that 20% number has changed in terms of those who are vaccine hesitant?
So through the chair, that continues to be the figure as far as we know with vaccine hesitancy writ large. You've seen some data that were presented based on a survey that we conducted on an interest in taking up this particular vaccine. And, given that we're dealing with a new virus and a new vaccine, there may be certain nuances or unique circumstances or concerns that people may have. But I would say that the figure that you have is just with respect to overall vaccine hesitancy writ large.
Okay, so my question is about children and youth in particular, and I know for children under the age of 14 that it's parents who make the decisions about whether or not their children are vaccinated. So once Toronto Public Health does the work to roll out the vaccine, are there any particular efforts that are being made in terms of communications to parents of children under the age of 14? And actually, given the percent positivity rates right now of the 14 to 17-year-old range, any particular communications to parents of that group of teens as well relative to vaccine safety? Thanks.
So through the chair, a couple of things. One, you know, I talked about how quickly and how remarkable it is. It is really an amazing achievement of science. People actually really working together towards development of a vaccine at this point. Now, the studies to date have not really been done in any significant way in young people yet. And knowing what the current recommendation is, both from the federal government and from provincial authorities, the focus is right now on particular populations, notably those who live in, who are seniors or more advanced in age and or support the care of those living in congregate living facilities for seniors, healthcare workers, and Indigenous communities, adults as well. So there is still some ongoing study that is happening in respect of the broader application of the vaccine, especially to younger populations. But there's no question that communications products and processes are actively underway. And this will naturally have to include communications around what the vaccine means for young people and how best to connect with parents on those discussions to support vaccine of younger or vaccination of younger individuals in our community.
Those are all my questions. Thanks very much again.
Thank you.
Thank you, Trustee Donaldson. Next, I have Director Sue Wong.
Thank you very much, Mr. Chair. I have 3 questions for the staff. So on the slide number 17, you share thank you so much for the presentation, by the way, to the entire public health team. With regard to slide number 17, you indicated that about the percentage of the staff, the residents in Toronto with excellence or very good mental health. Have you used those data, associate that with their social economic? Because there may be some relationship between their mental health and the social economics. I want to ask that first question. The second question, Mr. Chair, through you to the staff, with regard to this latest survey by Ipsos Reid, is this survey done in multi-language, whether by phone or by survey during the phone call? And then my last question, Mr. Chair, with regard to, I remember seeing on the PowerPoint slide that was shared with the board, that talks about the 37% of the resident that was interviewed indicated that media exaggerate the extent of the COVID-19. And given that one of the recommendations by staff using the data, how do we address this perception by the public that the media is exaggerating the severity of COVID-19? Because if this is pretty high percentage, almost 40% of Torontonians seeing that media is exaggerating the gravity of this disease, but more importantly, that this is a very serious problem with our community. So how do we address this issue in terms of public health messaging? So those are my 3 questions, Mr. Chair, to you, to the staff.
So through the chair, Liz, might I ask you to take the first 2 questions and then I'll do the last one.
Yeah, definitely. Great question. Ipsos did a really good job of targeting newcomer populations and lower income populations so that we could attempt to look at some of these questions by some of those social determinants. We're still in the process of exploring the data and seeing, what we have a big enough sample size to do and what maybe we don't have a big enough sample size to do. So that's some of our ongoing work for the next few weeks. And we plan to, keep using these data and keep reporting out on these data as much as possible because it's a very rich data source. There are a lot of topics addressed. And like I said, the sampling strategy was quite efficient. However, in response to your second question, unfortunately, it wasn't translated. So the survey was administered online to people who have signed up to work with Ipsos as panel poll participants. So having said that, of course, there is we have to take that into consideration when we're looking at some of the findings. As I said, they did target newcomers, which is great, but the newcomers would have to have proficiency in English in order to participate. So it's a limitation for sure.
And then through the chair, with respect to the final question, there's no doubt that there is some degree of media skepticism as expressed through this survey and through other channels that we hear about. I think that's why it's really important that our public, one, hears directly from us. You know, I realize that the media are part of that, but there are opportunities through, for example, the press briefing where we're able to connect more directly with our public so that it's clear that it is not exaggerated or overblown. And as well, we talked a little bit in this meeting around our partnership with trusted community partners, liaising with them and actually working with them to inform members of the community, again, in the context of very trusted relationships, people who they know are reliable with the kinds of information that they're putting out there. These are two just examples of the kinds of strategies we can adopt in order to get around some skepticism of the broader media.
Any further, Director Wong?
No, I'm good. Thank you, Mr. Chair.
Thank you very much. Next, I have Councillor Lai. Councillor Lai, when you're ready.
Thank you, Mr. Chair. Just a follow-up question on Director Sue Wong's question about the survey. By the way, thank you very much. It's a very, very comprehensive survey, and there's a lot of information and data in there. It will be on the website. Is that correct? Would it be published on the website? Those survey information.
Yes, so we currently have a slide deck with some high-level findings as an attachment to the Board of Health report that's also posted on the website. And we'll be doing some further exploration into the data and identifying the most important trends, in addition to what we've already shared that could be shared up.
So would you be doing a press release to some of the other media, let's say ethnic media, so that they will be in the loop of what's going on in the result of these surveys?
So through the chair, Councillor, what I'm going to suggest is we'll connect with our communications colleagues and make some determination as to how best to share the information. That may or may not include a news release, but certainly I think there's an opportunity to connect with ethnic media to make sure that the various communities around the city are aware of it.
Okay, thank you, Doctor. The next question I'm asking, it might be a million-dollar question, but from your professional expertise, Dr. Villa, can you give us a reason why we are on lockdown and then the numbers still going up?
Through the chair, how long do you have, Councillor?
5 minutes or 4.
Probably a little less.
But in a nutshell, what more can we do actually to make sure to flatten the curve, so to speak?
Well, I think you've probably heard me say many times, there's a role that we can play as government in order to create conditions that make it easier for people, if you will, to minimize their social interaction with others. We know that at the end of the day, COVID-19 is transmitted largely from close contact, one person who has an infection with another. And it's not always obvious who has COVID-19. It's not, there isn't a label or something that makes it easy to determine that somebody's got COVID-19. So frankly, the best thing that we can do at this time is for each and every one of us who has the ability to work from home, to stay home as much as possible, to only go out for those essential activities, to minimize our social interaction with others in person, so that you're really only interacting with close contact with those with whom you live. Of course, we continue to ask people that if you need to go out for whatever reason, for grocery shopping, for those essentials, for exercise, to wear your mask as much as possible, to wash your hands, and of course, to stay home when you're sick, not to interact with others when you are actually symptomatic. We have seen that the more people are able to adopt those behaviors, whether we're talking about our experience here in the spring or the experiences of other jurisdictions, the more people are able to do that, the less we see COVID-19 transmission. And frankly, the more effective our vaccine efforts will be.
Okay, thank you. I think my last question would be, how at your call center at TPH, how many people are working there? Are you swamped with the calls, and is it getting better? How long is the wait if someone have to call the inquiry line?
So I do believe through the chair that does vary depending on what's happening in the city at any given moment in time. I don't have exact figures. I do have a number of colleagues from the team. Does anyone have a specific answer for that question? If not, Councillor, we'll come back to you.
Okay, no problem. Thank you. Those are my questions,
Okay.
Mr. Chair.
Thank you, Councillor.
Councillor Lai, let me just do a final caucus for any other members of the board with questions on this item. Okay, seeing none, I just have a couple. Dr. Davila, just a couple for you at a very high level. First of all, as we look to January, based on the current rate of reproduction number, based on the modeling, based on the potential for holiday gatherings, is it fair to say that we are heading towards January being the worst month of the pandemic thus far in terms of case counts, hospitalizations, and potentially fatalities?
So through you, Mr. Chair, you know, it's always dangerous to make predictions, but certainly we have reason to be very concerned. Our R continues to be above 1, which means that the outbreak continues to grow. If there is increased interaction amongst people, residents of the city and beyond, we can expect that there will be ongoing and further transmission of COVID-19. It's that simple.
And if it's, you know, based on the R number as it is today, are you concerned that if there are gatherings beyond what is recommended by public health officials over the holidays, that this will result in an even further spike and perhaps an even higher rate of reproduction number?
So briefly, yes.
Okay. Do you believe with both enhanced measures, enhanced investments in test, trace, and isolate, enhanced compliance to the recommendations out there, can we still beat this second wave?
So through you, Mr. Chair, we certainly have the capacity to impact transmission and to reduce it. There's no question. The more we adhere to public health measures, the better off we will be as a community from a COVID-19 impact perspective.
Okay. And then the other, so that just at a high level, that's helpful as an insight as we forecast to January. On vaccines, so I mean, there's a lot of discourse about vaccines and a lot of excitement in the context of, you know, rollout. Could you tell us from an immunization perspective what herd immunity means and is, and what percentage we are targeting of vaccine uptake to achieve it for this particular vaccine? Or this particular set of COVID vaccines, I should say.
Sure. So through you, Mr. Chair, there's no question that we're very excited, I think, writ large in the global public health community around vaccine. And what we're looking for in the case of communicable diseases is when you get to a certain level of immunity across a population, it just makes it that much harder for a disease to continue to transmit and spread and wreak havoc on that population. So the concept is to try to get as much immunity as you can with, for example, the use of a vaccine when we're talking about vaccine preventable diseases. This is still a new disease and a new vaccine. But what has been put out there in the public based on the best available scientific evidence is that they're aiming in and around for something of 70% coverage in order to have sufficient immunity in the population such that the disease will not continue to present as significant a risk as it currently does right now.
And can you tell us, by way of a comparison, if the target has been set at over 70%, I assume that's by our federal counterparts who have set that target, is that correct?
So it's largely from the global public health community premised on the best available science. And there is a bit of a range, but we're using roughly this figure of 70% for now.
Okay, so using for now, this figure is 70% based on global public health discourse. By way of a comparison, have we achieved over 70% vaccination rates for other communicable diseases for which we vaccinate in this city and country? Like, is over 70% a bar that Canadians should not expect to meet, or is it a bar based on other efforts and other vaccines that we can meet with the right approach?
So, through you, Mr. Chair, it's interesting. When we look at immunization coverage, it largely focuses on that programs that we have specifically designated for kids. And there, yes, we do achieve those standards. This one's a little different in that we're talking about a vaccine that will be applied across the entire population. And so, it's very difficult to predict with a brand new vaccine. But certainly in respect of children, we know that with childhood immunizations, we are able to exceed that standard.
Okay. Those are my questions. Thank you very much. Let me just do a final call for questions. Okay, seeing none, we're going to move it into speakers. And I'll take a list here. Speakers on this item. I see by way of a show of hands, any speakers on this item? Okay, and then for those who I can't see, if you just wish to unmute, if you wish to speak, otherwise I will put myself on as the sole speaker. Okay, so let me begin. First of all, then let me ask, there is 2 small amendments, and I will ask clerks to place them on the screen. The first is to request the medical officer of health alongside Toronto's COVID-19 incident commander, that's Chief Pegg, who attended earlier, to provide a presentation at our January meeting on the status of Toronto's immunization task force and the various preparations underway, from intergovernmental coordination to prioritization, distribution, targeted approaches to distribution based on our equity action plan, and other local work being done. The second amendment is at the request of City Legal. This is the medical officer of health has issued a series of Section 22 orders over the course of this pandemic. City Legal have advised that they require direction from our board in order to seek recovery costs incurred during carrying out the MOH's direction. And so at the request of City Legal, I'll move that. So I will move those 2 amendments, one at the request of City Legal and the other on vaccinations. As well, I will move the staff recommendations that are in front of us. I don't need to belabor it. Others have, with my deepest thanks and gratitude to Dr. Davila and the entire Toronto Public Health team. I can tell you that they are battling right now. They have been going for 11 straight months. Like everybody in our city, they are not only tired and worn down, but they are carrying the emotional burden of the work that this entails. And they are doing so with everything they've gotten, with exceptional skill, professionalism, and courage, I would argue. And so 11 months into a pandemic, I would focus my comments on 2 objectives in front of us today. And I think the presentation and the recommendations speak to both. The first is to beat this second wave. That's the first objective. And the second is to plan for and roll out the largest immunization campaign in our country's history, collectively with the other levels of government. Can we beat this second wave? We can. Other jurisdictions have shown us the way. Are we in a position today where we are headed towards arguably the worst months in the entire pandemic as we look to January and February? We are. I will tell you that I'm deeply concerned that based on the current rate of reproduction, the modeling, the combination of general COVID fatigue and December holidays coming soon, and the absence of effective policies from all levels of government to protect those hardest hit and marginalized communities, it has set us on a path for arguably a perfect storm in a brutal January. And I think we have to be honest about that, because that recognition has to inform the urgency of our collective response today. And that urgency, as demonstrated by other jurisdictions, can be seized with the right measures. Strict public health interventions to reduce contacts and collective and individual adherence to them. Enhanced protections for frontline workers and marginalized communities. Stronger test, trace, and isolate systems. And I would tell you, stronger measures to support residents to cope with this painful period. It's winter, it's dark, it's cold, and people have been struggling for a long time. You take all of those measures together, public health interventions, enhanced protections, stronger public health systems, and measures to allow residents to cope, and you do all that, and we can prevent a brutal January and February. We do not have to accept that January and February will see increased cases, increased hospitalizations, and increased deaths. But that is the path we're on if collectively, as all levels of government, we don't respond harder. That's the first objective. And the second, I do want to mention on this immunization campaign. Last month, we received at our board a detailed update on Toronto's vaccine task force, and this board made specific recommendations around prioritization. Next month, we will be receiving a detailed presentation on the status of Toronto's work and its partnership with the other levels of government. And there have been, as Dr. Davila noted, heroic efforts from the scientific community, nothing less than heroic. But the efforts of the scientific community to develop a vaccine is only the first step. The efficacy of a vaccine is based on its safety. That step has been met and will continue to be met as other vaccines are approved. The effectiveness of a vaccine is based on its uptake. It's based on herd immunity. And so we talk a lot at the Board of Health with our public health hats on. Let me put my political hat on. We need to win 70% of the votes of all registered voters. We need to ensure that those who want a vaccine and are able to access it can. We need to ensure that those who want a vaccine but need help accessing it can. And we need to ensure that those who are unsure or hesitant about a vaccine have the trust in it and are convinced of its efficacy in order to take it. And so we need to do all of those things as three orders of government to achieve herd immunity. In political words, to win 70% of not just the vote, of all registered voters. In this case, kids can vote too. And so a prioritized rollout to mitigate harm and protect people is key, but a targeted rollout by all levels of government focused on those hard to reach neighborhoods and focused on building trust with those who are unsure and hesitant is critical. And so I'll conclude by my remarks by simply reaffirming that which we've said as a board every month for 11 months. Our task today is the same as it ever was. Not only to beat COVID and roll out an immunization campaign to help do so, but to address the fundamental inequalities and inequities that COVID has laid bare to protect the health of Torontonians in the future. Thank you very much. With that, with the concurrence of the board, and I'll check, we would move the staff recommendations with the amendment recommended by City Legal and on vaccines for presentation. Would anybody like to vote on those separately, or can we take those as a package? Okay, we'll take those as a package. All those in favor, by way of a show of hands. Opposed, if any? Thank you, that carries. We will now move to our final item, which is the new business item. This is item 24.6, student nutrition program support for remote learning. We introduced this at the beginning and it's being circulated. Let me start by seeing if there are any questions of staff on this item. Okay, seeing none, to speak, Trustee LaPredi, did you want to say a few words off the top?
Thank you so much. Thank you. Thank you for giving me the opportunity to speak, and thank you for taking our calls last week. In a normal year, SNPs, which is a student nutrition program, feeds some 61,000 students at the TCDSB. We serve about 1.2 million meals per month, or just under 11 meals each academic year. But with COVID, this isn't a normal year. SNP funds are used for in-school food nutrition related expenses, cannot be allocated to students in remote virtual learning environments. Food insecurity is a reality which is exacerbated by COVID-19, especially in COVID hotspot communities. Currently, up to 30% of students within our schools are in remote learning, which is at-home learning. And that would suggest a significant number of students were not receiving any access to the nutrition programs that they would be entitled to in the year. About 30% of total SMP funding, this proportion of provincial funds is not enough to extend the nutrition to meet the needs of virtual learners. So I really thank you, Councillor Cressy, for putting this motion forward, because this motion would allow up to 30% of the Toronto Public Health student nutrition funding to be used for remote virtual learners through grocery cards, as we did previously in the first lockdown of March to June.
Thank you, Trustee Lopretti. I'll put myself next to speak on this, and then we'll see if there are further speakers. Just building on what Trustee Lopretti mentioned, we've heard from a number of our school counterparts and trustee counterparts that in this second wave, a number of students who would normally access student nutrition programs in school, in class, are unable to currently, either due to cohort class closures or school closures, or due to virtual learning. And so the recommendations in front of us target two twin objectives. First is to enable flexibility during the second wave so that local schools are able to ensure that those virtual learners or those affected by closures and are able to access food. And secondly, to ensure that we can do so in a way that doesn't undermine existing student nutrition in-class programs. The cost of food has gone up. The cost of running the program in many cases has gone up. So we need to ensure there is access to nutritious food for those who are at home, but not at the expense of those who continue to access the student nutrition program in person. And so the recommendations in front of us here today specifically are to enable that flexibility, to request the other two levels of government to support us in allocating funds for those extraordinary costs, and to authorize from the city the use of any surplus student nutrition program funding we have in year right now to support those two objectives. So that's the context and the background, and I do want to thank Trustee Lopretti and Trustee Domenico, who is a member of the TCDSB board, who have been working closely with Toronto Public Health staff and our office to bring this forward. So those are my comments, and I should formally say I'll move the recommendations included in the letter here. Are there anybody else who are there other members of the board who wish to speak on this item? Okay, with that, all those in favor of the recommendations in front of us? Opposed, if any? Seeing none, that carries. Members of the board, that concludes our agenda. It's only 12:15. It feels like we've been here all day. Maybe that's just me. But thank you from the bottom of my heart. Have a safe holidays. Don't stick in your household. Don't talk to anybody outside of your household unless it's virtual. And the work continues. We got a busy few months ahead of us. Keep it up, everybody. Thank you.